So yes, I said I would talk today about new agents, and this is a slide from about a year ago at a presentation at the American Society of Haematology, and this looks quite exciting and busy. Um, but you'll see from how long my presentation is that it's perhaps not as exciting and busy as we might like it to be. Um, so I'm just going to walk you through this slide and then talk in a bit more detail about two of the agents that I think might be of interest to the group that might be coming through. Um, so these different pathways are pathways that we think are relevant in patients that have low risk MDS. And I'm going to start on this side here where we're talking about targeted therapies. So these drugs have been around for a long time, and they are drugs that target certain genetic abnormalities that we see in a small subset of patients that have MDS. So this drug, ivosidenib, is now approved for the use in patients who have an IDH1 mutation, one of the specific IDH1 mutations in patients who have AML. And there are ongoing studies in the MDS space for these abnormalities. But as is commonly the case, these tend to be studies that are going on in the higher risk population. And so far, there's nothing approved in Europe for patients who have MDS. But in terms of lower risk MDS, I think there is some rationale that patients who have these mutations may have a higher risk of progression. Well, that's debated. That's some of the literature suggests yes, some no. And so these agents may come through for lower risk patients at some point in time, but not there yet. And similarly, IDH2 inhibitors are widely available in the US, but have yet to be approved anywhere in Europe. So parked in the MDS space, but I think at some point are likely to become available, just not in the immediate near future for us. Then a couple of years ago, this drug, H3B8800, came along. This is a drug which interferes with the spliceosome. So one of the most common mutations that we see in MDS patients is SF3B1. There are other spliceosome inhibitors such as SRSF2, and these drugs were designed to try and modulate the spliceosome, which is what these mutations are part of. However, again, the data from the studies has been suboptimal. It was only in phase 1 studies, which basically is looking at safety. Safety is fine, but there was no clear signal that this agent was going to do something useful in MDS patients. So in this sort of targeted therapy space, there's not an awful lot of movement in MDS. And that's a bit disappointing because in the AML space, that's really moved forward quite rapidly. So then moving on to this inflammasome inhibitor space. So there's a lot of interest in this because there's quite a lot of evidence evolving that patients who have low risk MDS have lots of inflammation in their bone marrow. And that's one of the things that may drive progression to higher risk MDS. And so there's a number of agents that have been trialed. Unfortunately, so far, of these three agents that are here, the tomaralalib, can't even say it, this one is no longer available. The company did a study. It inhibited something called toll-like receptor 2. And although the drug was trialed in a number of spaces, including in MDS, the company couldn't sell the drug for later phase trials because the signal wasn't strong enough and the agent's no longer available. Then this agent too has been trialled in MDS patients in phase 1 study, the BMS 986253. That inhibits something called IL-8. And that's another inflammatory component of that we see increased in the bone marrow in patients who have MDS. And again, there wasn't really a signal that this was going to be efficacious in MDS patients, and further studies are no longer ongoing. And the one at the top, SX682, this drug inhibits two receptors. So these receptors are involved in how inflammation in the bone marrow is perceived in cells. So basically stops the signal of inflammation from having its effect. And this has been in clinical trials for MDS. And so far, there's nothing reported on these studies, and they're still recruiting. So there's still a potential for this drug to potentially have an effect in MDS, but we don't really know. I'm going to skip over to this drug called canakinumab. This drug affects a signaling pathway and is available, this drug. It has a license for various inflammatory conditions. And there's another sort of sister drug called anakinra, and anakinra is quite widely used in the haematology space for other indications. And so there's currently an ongoing trial of canakinumab, and I think there's quite a lot of excitement that this might be a useful agent because it suppresses inflammation very rapidly when we use it in other instances. And it only needs to be given once a month. So I think one of the issues with some of these agents is that they're intravenous or they're subcutaneous, and they, in terms of sort of quality of life of somebody who's got low risk MDS, then it's not particularly ideal in that setting. But canakinumab only needs to be given once a month. And as the UK group, we've talked about whether we could get canakinumab into a study for patients who have particularly inflammatory types of MDS. And those patients are patients often that have kind of autoimmune type problems, and often have the CMML subtype of MDS. So that sort of just puts that in the context of UK, but the current study, which is I think at the MD Anderson in the US, is ongoing. So again, watch this space for that drug. I'm going to skip back to this HIF pathway inhibitor thing here. So roxadustat was in phase 3 clinical trials, and it inhibits this HIF alpha pathway, which is another inflammatory type pathway, and it also is required for the development of normal stem cells. But so far, phase 3 data do not support that roxadustat is useful in patients who have MDS. So again, it's another trial that looked very promising at phase 2, and phase 3 data hasn't supported that. So I'm almost done with bad news. So this drug, emavusertib, this is quite a new agent. So this drug's only really recently gone into clinical trials. It inhibits something called IRAK4, which is a slightly different inflammatory signaling pathway, which has in particularly been implicated in patients who have 5q- syndrome. But it's being trialled in all MDS patients, and that clinical trial is in phase 1 in the US and is currently underway. So watch this space for that one. So the two that I'm going to talk about a little bit more are this one here, imetelstat, and this one over here, which is down here is KER-050, but it's also got another name now. It's got a real name, the drug name. So let's start with imetelstat. So imetelstat is a telomerase inhibitor. So what is telomerase? Telomerase is something that is at the end of your chromosomes. So at the end of your chromosome, you have what's called a telomere. And telomeres are there to stop your chromosomes from sticking to each other. So if you look at the picture, you can see these are chromosomes. You've got, a pair of chromosomes that are stuck together in the middle. And each of these chromosomes, one comes from your mum, one comes from your dad. That's how you get all your genetic information. But you see, they've got ends. And the reason that the ends don't just kind of stick to each other or stick to themselves is because they're protected at the end by something called a telomere. And telomeres are maintained in some cells in the body. And in other cells in the body, when cells divide, the telomeres get shorter, and eventually, when the telomeres get really short, the cells die. And that's a sort of protective mechanism, which means that most cells in our bodies have a limited life expectancy. So, for example, an average neutrophil will only live for about a day. An average platelet might last for about a week. And as we know, red blood cells last a little bit longer than that. But one of the reasons, and that's just talking about blood, but the same is true of any part of your body, really. All cells that aren't stem cells, essentially, eventually they will die. And part of the reason they will die is when they divide, the telomeres get shorter and then they get programmed to die because they've got short telomeres. That's normal. In stem cells, on the other hand, we have a mechanism that keeps stem cells alive, because you need your stem cells to survive for your whole life, because that's what gives you your entire blood pool. So a blood stem cell, hematopoietic stem cell, lives your whole life in your body and gives you your entire blood production. So that's the case both in normal and in a blood stem cell that's become abnormal, become MDS or AML or whatever type of abnormal stem cell that you happen to have. So in stem cells, we have an enzyme called telomerase, and telomerase allows us to increase that telomere end so that it doesn't die. It keeps the cell alive by making sure that we maintain the end of the chromosome to be longer and to have an adequate telomere length. So this drug is designed to mimic where the enzyme telomerase binds and thereby stop the ends of the chromosome from being maintained in your abnormal MDS stem cells and cause them to die. And that's how it is proposed to work. And what the goal is, therefore, is to kill off the MDS stem cells and stop them from predominating in the pool of cells that you have. So this drug has been through a phase 3 clinical trial, and the name of the study was the iMerge study. And the goal of the study was to look in low-risk MDS patients who were transfusion dependent for the development of transfusion independence. And that was called the primary endpoint, was transfusion independence. And 40% of patients reached this primary endpoint who received the drug. The drug is given monthly by subcutaneous injection. And more responses were seen in this SF3B1 mutated group. So that's the same group of patients that also respond to luspatercept. But there was still a lot of responses in the patients who didn't have SF3B1 mutations. The other thing to say about the study was they used a very old scoring system. So they used the IPSS, which is about 3 scoring systems ago. And so the benefit of that is actually that the license reflects the IPSS scoring system. So lots of people would have an IPSS lower intermediate 1 score, who now might have a higher risk score. So they might have access to that drug if it gets approved for use. So that's a benefit. There was a tendency for patients who had more than 3 mutations to not respond so well to the drug. But for me, the most exciting thing about this drug is that it appears to modify the actual disease. So things like EPO work well because they stimulate production of red cells. But they're just still your MDS cells. They just make more of your MDS cells. And they alleviate symptoms, and that's great, and that's the goal. But in this setting, the drug actually seems to reduce the burden of disease. So although the study didn't look at whether or not people lived longer, because it's very hard to do that in low-risk MDS patients because we expect them to live quite a long time, my sense is that that's going to be something that might come out of these studies at a later time point, because if you reduce the burden of the actual disease mutations, that would seem likely that might also prolong survival. So they didn't look at that in the studies, but that would be my kind of, as a sort of exciting take on it, is that it looks to change the way in which the disease is functioning. So this is a very exciting study, I think. the duration of the responses wasn't outstanding. You know, it was like 1.5 to 2 years. So it's not massively more than what we see in patients who are on EPO, for example. And I do have a little bit of concern. And the reason I have a little bit of concern is because the mechanism, this telomerase system, we know that a subset of patients who have MDS actually have short telomeres, and that's bad. And people who have short telomeres get aplastic anemia. So one of the major side effects was low neutrophil count, and that may be because you're also leading to sort of side effects that might be related to the function of telomerase in a normal cell rather than your abnormal cell. However, I still think it's quite exciting. This has just been approved in December by the European Medicines Association. It's been approved in the US for a little bit over a year. And the last I looked on the NICE website, it was that at the beginning of last year, they had postponed their discussions, awaiting when they were going to be getting their European Medicines Association approval. But as always, particularly in the low-risk population, cost is a big issue because it has to compete with transfusions, really. And transfusions are expensive and inconvenient, but they're not as expensive as these drugs. So I think if and when this does come through NICE, support from groups like yourself are absolutely critical, because one of the ways NICE assesses drugs is about quality of life, and quality of life is going to be the real selling point for patients who don't have to come to hospital for transfusions. So if and when it comes to NICE approval, and I'm in any way involved in that, I will be getting back to people to get some support from this group. So watch this space. So that's quite exciting. Then this drug, elritercept, this is not a new mechanism. This is the same mechanism that we see in luspatercept. It's sort of friend of luspatercept, but it is a new drug. And it does seem to have some slightly different effects. So the way this drug works is by sequestering this thing called activin. And when there's too much activin, you don't get appropriate signaling to make as many red blood cells and platelets and white blood cells. And it also seems to have an effect on iron overload. So useful in patients who may have had some transfusions, or patients who may need some concomitant transfusion, even if it's less than what they needed before. And so this, got another picture here. Yeah, nice picture. The other thing that's nice about this is it doesn't just improve red blood cell production, it improves platelet production. So for people who also have low platelets or only have low platelets, then it may be a useful drug. So this is now in phase 3 clinical trials in the UK. It's open for recruitment that I'm aware of at King's College Hospital, but there will be other centres in the UK. And I notice it's not on the MDS UK website, but I think this is another potentially useful new drug. It's a phase 3 clinical trial, and the downside of the phase 3 clinical trials is that sometimes you don't get the drug. So that's the only caveat to that, is that it's randomized. You're randomized to receive either the drug or a placebo. But that's the only way we get things approved, is if we can prove that there's no effect of the placebo and that it's all down to the drug. So I think hopefully this is a drug that might come to market. And I think one of the benefits of that would be if there's some competition for luspatercept, it might also push prices down a little bit, because we haven't been able to access luspatercept so far in the UK because of pricing.